Hey everyone, welcome to tonight's webinar, Wu University Current Opinions in Eyelid Health, presented by Dr. Paul Karpecki, Dr. Melissa Barnett, and Dr. Tracy Dahl. Thank you so much to our amazing speakers for being here. I'm Dr. Elise Kramer. I'm currently in Miami. Where are you guys located?
I'm in Northern California.
Lexington. Sorry, yep, Northern California. Tracy?
Portland, yeah.
That's right. And I'm in Lexington, Kentucky. Not as glamorous. Yeah, there are three of you.
Well, thanks so much for being here tonight. Thank you for all our participants as well for attending, and we're all excited to learn from you, as we always learn so much. Next slide. Thank you to Visionary Medical Education for helping host this event. Next slide. And thank you to OcuSci for sponsoring this event. Thank you to Tea Pharma and Sun Pharma for supporting this event with a medical education grant. Before we get started, you'll see a question there in your chat. Please click on it so that we can have your response. It's important for us in order to get these grants to have free activities for you, free events. Please take the time to answer the question that you see in the chat below. And I'll just go over a few housekeeping items here. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. This is a 1-hour CE course, so please stay online for 50 minutes in order to obtain your CE credit. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There's also going to be a QR code at the end of the event. So if you have the OE tracker app on your phone, you can get instant CE by scanning the QR code. If you don't have the OE tracker app, don't worry, you will still get your CE certificate by email within about 4 weeks. You cannot use your camera on your smartphone. You will need the OE tracker app. But again, if you don't have that, don't worry, you'll still get your CE certificate. You can ask questions using the Zoom on-screen floating panel that you see circled here below. Next slide. And if you're using the mobile version, if you're using the mobile version, you'll see the Q&A above, and you can see the 3 dots at the bottom where you can click and see the chat below. So if you are using the mobile version, click Q&A at the top. To ask questions to our speakers, click the 3 points at the bottom if you want to use the chat and ask logistic questions. Next slide. So without further ado, I will introduce our amazing speakers. Dr. Paul Karpecki received his Doctor of Optometry degree from the Indiana University and completed a fellowship in the Medical Corneal and Kansas City in affiliation with the Pennsylvania College of Optometry. He currently serves as Director of Cornea and External Disease for the Kentucky Eye Institute in Lexington, Kentucky. He served on the TFOS-DUES-2 Diagnostic Methodology Subcommittee and EWS-3 Treatment Subcommittee, as well as the co-chaired the previous 2 and upcoming TFOS Symposia. Dr. Karpecki is an associate professor at the Kentucky College of Optometry and teaching at the University of Pikeville. Thank you so much, Dr. Karpecki, for being here with us.
Thanks. Thank you.
Next slide. These are the financial disclosures. Dr. Melissa Barnett is a world-renowned key opinion leader recognized for her expertise in specialty and scleral lenses, dry eye disease, keratoconus, and presbyopia. She has authored more than 275 articles and books, served on several industry boards, and delivered over 350 lectures. Her work has been featured in medical journals, professional magazines, as well as consumer publications such as Bloomberg Prevention Magazine and Good Housekeeping. She is energized by her passion for helping people improve their lives by optimizing vision, health, and wellness with a customized approach. Dr. Barnett is most proud of being awarded the Scleral Lens Practitioner of the Year from the Scleral Lens Education Society, the inaugural Thea Award for Excellence for Mentoring by Women in Optometry, and was granted the Most Influential Woman in Optical from Vision Monday. Dr. Barnett is the Director of Optometry at the University of California, Davis, and is the host of Clearly KC podcast. She advocates for elevating eye care through technology and her influence on the profession. Thank you so much, Dr. Barnett, for being here.
Oh, thank you for having me.
These are her financial disclosures. Dr. Tracy Dahl is the Director of Ocular Surface Care Services at the Sunset Eye Clinic in Beaverton, Oregon, blending ocular surface disease therapy with an aesthetic twist. Her personal treatment philosophy is clean, calm, protect, and beautify. Dr. Dahl graduated from the Pacific University College of Optometry in 2006 and completed a residency with the Portland VA Medical Center in primary care in 2007. She then embarked on a 15-year teaching career with Pacific University College of Optometry, instructing in didactic courses and clinical services for first through fourth year students. She pioneered one of the first ocular surface dryness centers inside a university. Dr. Dahl has a passion for lecturing, writing, and research on the topic of improving ocular surface dryness and safe eye beauty. She was thrilled to take part in the TFOS Tear Film and Ocular Surface Society workshop, a lifestyle epidemic ocular surface dryness as part of the subcommittee on cosmetics. Dr. Dahl is delighted to serve on the American Academy of Optometry Anterior Segment Section leadership team and is a proud member of the Intrepid Eye Society and TFOS. She is also a co-medical editor for Dry Eye Coach, offering online resources for doctors and the public alike. Thank you so much, Dr. Dahl, for being here.
Thank you so much. It's such an honor to be here with two of my favorite people in the ocular surface space. So hopefully we all just have a really great time and learn a lot tonight. Thank you.
Thank you, guys. So I'll let you take it away, and I will be on later for questions.
Thank you.
Okay, I guess I'm starting first. So I'm going to start talking about one of my favorite topics, which is something that's with us all the time as part of our normal biomicrome. But when the populations of these little mites that are normally always with us tend to get out of control, we end up with what's causing 2/3 of blepharitis. These are cute little Demodex mites. This is Demodex folliculorum and brevis. I like to call them cute so they're not as creepy to my patients. Folliculorum are the ones that we tend to find along eyelashes or cilia because they're longer, whereas the brevis, kind of like little brief, they tend to hang out more in our meibomian glands and our sebaceous glands on our skin. And the reason that they're there is they actually do serve a little bit of a purpose. They're kind of like the stray cats that hang out on our face. They eat dead skin cells, thicken sebum, and they do that cleanup work of the extra things we don't need anymore, like our glandular and follicular epithelial cells that are shedding. But when you become too good of a food source, their populations get a little bit out of control. So demodicosis is defined as more than 5 mites per eyelash follicle. And 2 key things that you need to know about these little guys is that they like to come out at night, and their life cycle is 2 to 3 weeks. So when I'm thinking about trying to control their populations that get a little out of control, the time they come out to reproduce and their life cycle is a really important fact to consider. So next slide. They don't just come in by themselves. They actually bring little friends along with them. So I don't know, I was taught in school originally that the main cause of blepharitis was staph, right? Staph and strep bacteria. And those didn't exactly go away, but what we found out is they're actually hitchhiking on the back of our little Demodex friends. And our Demodex also have their own endogenous species. And antigens to these extra bacteria can cause inflammatory reactions on the ocular surface, hypersensitivity reactions. We know that we found inflammatory white blood cells in association with these mites. And I did spend an entire summer plucking mites to work on a paper with some great doctors across the country to show that it does cause an increase in MMP9, so localized inflammation when you have more mites. So we like them. They do serve a purpose, but too many of them are a problem. And when you get too many of them, this is all of the sequelae that can come with it. Too many mites alongside lashes can cause irregular lash health like trichiasis and matarosis. The body itself doesn't always like these mites. So if you've got those patients with recurrent lid lesions that tend to move around a lot, you might want to consider Demodex mites because the body itself will try to wall those little guys off. You can see the inflammation in the conjunctiva and in the cornea. If you've got these flectenule-like opacities or infiltrates, sometimes it's good to rule out Demodex. And then, of course, looking at the lid margin, you get the cylindrical dandruff or buildup around the base of the lashes, and that's pathognomonic. That means that's the only thing that's going to cause it is going to be Demodex mites. So anytime you see that cylindrical dandruff, it's like those little mites hung a "we live here" sign right on the edge of that eyelash. They're down in there. And then again, that summer I spent plucking mites proved that to me. Every time I saw that cylindrical dandruff, there were plenty of mites to follow when I looked at lashes under a microscope. Next slide. And you can be pretty symptomatic with these with other conditions that can have a crossover. I've had a lot of patients that mistakenly think that they have allergies because of the itch and the redness and then the irritation. But you can also be completely asymptomatic. Some patients have no idea that they have this base crustiness at their lashes, and they have no idea that these extra mites are living there. So signs and symptoms don't always correlate, which is why it's our job to go on a mite hunt every time we look in our slit lamps. Next slide.
So I love how you say the mite hunt. And what I've learned here is to ask my patients about the itch, the location of the itch. So it's not the eyeball itch, it's at the base of the lashes. And when you ask your patients, where do your eyes itch? Then they tell you, oh yeah, it's right here at the eyelash margin. It's really interesting.
It is. And even more specific is the most common area of itching for allergic conjunctivitis, if you're trying to differentiate the two, is in the canthal region. So, if they're that specific, it's probably allergic conjunctivitis. If it's eyelid margin, as you said, it probably is blepharitis and most likely Demodex. It's good insight.
So the trick to finding these is to make sure that you're looking in the right location. So Demodex collarettes you can completely miss, and I'm embarrassed because I probably missed them a lot when I didn't know how to look for them. Because here's a good example of a patient that came in. You can see her looking straight ahead. You do see a little bit of, that irritation, a little bit of inflammation of the lid margin. But when she looks down, next slide, there it is. So this was subtle enough that I didn't catch it looking straight ahead, but looking down, there they are. And this patient was symptomatic of itch, irritation, and dry eye-like symptoms. So even something that's this subtle can cause patients plenty of irritation. Thank you. Now, I do get this question a lot because some people clean their lashes really, really well. And other people like to coat their lashes really well with cosmetics. So sometimes you might miss those collarettes. So is there another way that you can potentially detect their existence? And a colleague of mine, Dr. Laura Perryman, which many of you may know, she's developed this new sign called the Appenglow sign. I think I told you that these guys move around. I did find lash mites in the skin and skin mites in the lashes. So you can sometimes find these hanging on to the coarser hair right over the bridge of the nose. So it doesn't take much to slide that slit lamp down, zoom in where, you usually are trying to stay away from. We try to get off the nose, but you put it there and you look for those little mites and you can find them. So this is great for those extra mascara coated lashes of patients who, wear it in and you're looking for it, or patients that are really good at scrubbing and getting those crusts off. So next slide. We can also kind of think about who are our common hosts. Those are usually the people that are the better food sources. So people with increased age, those with autoimmune conditions can often have thrown off biomicrobes, so you might get more of mites and bacteria than usual. Skin conditions like eczema and rosacea. We'll get back to rosacea throughout this presentation. And then contact lens wearers. This was really interesting. I think you're the one that told me about this one, Melissa. There was a study of 40 contact lens wearers that showed that they have more mites than those who don't. So I thought that was pretty interesting. Any theories as to why that is? Would it be the
again, it could be a really good food source. So we do need to rule out Demodex in all of our contact lens wearers. It can be in 90% of contact lens wearers. So I think that this is a great option for contact lens retention or keeping our patients in contact lenses, because we know that contact lens dropout is highly prevalent. And just addressing the ocular surface, specifically looking for things like Demodex, is really helpful to keep our patients in contact lenses, keep them comfortable.
Right. So I'm going to go over some treatment options that have been out there, some things that have tried that work, and some newer things that maybe some of us haven't had a chance to get our hands on. So next slide. I started with tea tree oil. There was a really great paper that came out of Australia showing that 50% had a direct killing effect on these mites. So early in my career, I was slathering lids with tea tree oil, trying to get those mites under control. And then different formulations came out after that that showed that they had the ability to impact the life cycle of them, and also killing the bacteria without breeding resistance. So it was a really great treatment, what I started with, because when I had it. But next slide. But what we do know about tea tree oil is it may not entirely be without consequence. Yes, it does have that ability to get the populations under control, but it may also not quite be the healthiest for our meibomian glands. And so we have to be careful about what we choose for long-term use. Maybe short-term, it could be okay, and I'll get your all's opinion on that. But there was a study that looked at how it affected human meibomian gland epithelial cells. This wasn't on a live patient walking around and moving, but it definitely had issues with causing morphological changes in the meibomian glands, and then cell death after a very short period of time at a pretty low concentration of 1%. We also know that tea tree oil may possess some pro-estrogen and anti-androgen effects. And so in some of our patients that are sensitive to those hormonal changes that are happening in the body, this may not be the best choice if we're tipping over towards the estrogen side versus the androgen side. So are you all still recommending tea tree oil, or are you doing some of the things I'm about to talk about?
Yeah, I
Doing the
think we
things
do
you're
the
about to
same.
talk about.
Yeah, we would, it was all we had at one point. I remember mixing 50% concentrations before even commercial versions. And, it was tough on patients. Now I would probably only use that in patients I don't want to come back. There's just better things, I think, here as you're leading into, and I agree with you.
Next slide. So another potential ingredient that has the ability to have effects on Demodex is the okra plant, actually. So the active ingredient in okra actually has been shown to have equivalent ability to tea tree oil and metronidazole in the Demodexic effects. It is a little bit more comfortable, however, when compared directly with tea tree oil. So okra as an ingredient in a chronic lid scrub is kind of more where I'm moving for lid hygiene if I feel like I need somebody with lid hygiene that's effective against these mites. So that's an update in what I use for lid scrubs. Next.
Yeah, and another one too is Manuka honey, if you can get it. No, it's not the honey, it's the extract from the leaves, but I found that and okra are probably the best options currently today. I agree.
Is used in the UK and in Australia, so they actually have pharmaceutical preparations for that there. Yeah, good solid choices. So this was a controversial one. I get asked about this one all the time. Ivermectin for Demodex. It is effective on the chloride channels of invertebrates. So it actually causes them to become paralyzed, and then the parasites, unfortunately, they pass away. So ivermectin is an effective treatment for parasitic infections. Go ahead and go next slide. It is considered to be off-label whether you're prescribing it orally or topically, but yes, I have tried both before newer options. It's pretty well tolerated systemically. Most of my patients who I tried it only maybe had some mild gastrointestinal effects, but I did find it wasn't as effective as I sort of hoped it would be. So I don't know if you guys have tried the oral, but I think the topical works a lot better because you're sticking it locally where the issue is. But there's no...
I've used the oral, your question. I've same thing. I had a patient who was just felt like they were crawling on her eyes. I wish I hadn't told her she had mites. This was way before we had Lotilaner, and I just had to try something because it was affecting her mentally. And so I went ahead and dosed it. The problem is you got to dose it per kilogram. You don't want to be too high because of toxicity. You got to really watch what you're doing on it. And honestly, shouldn't look any different. But maybe it helped her because it was a weird feeling, and that's all I wanted to do. So I've got experience in like 7 patients, maybe. I've not had huge success with orals. Topical, I don't know if I have the wrong ones, but they were I think they hurt more than 50%. Tea tree oil, when I used it on the eyelids, patients did not want to come back.
Topical anesthesia, you're right. It's exactly the same you do with tea tree oil. Like totally the same. I agree with you, Paul. Yeah. There's no standardized way of doing it. There's been a couple of really good publications that have showed different applications. The one at the top was like once weekly. There was another one that said, apply it one time, let it sit there. And then that lasted upwards of about 12 months. So I have used this in patients before we had other options, or if we can't get anything else. But, they basically have to stand in the shower, rub it into their lashes, let it sit there for 5 minutes, and then pour that water on their face because it's irritating. It works, but it's like the 50% tea tree oil. It's irritating.
Yeah, if you can get them into their car before the anesthetic wears off, you might be able to get away with it. But that's about it. Yep.
This is fantastic that we have much better options to discuss tonight.
And next slide. So yay. So what it turns out that there is now, and I've been prescribing this. I started writing this the day that it became available. This was FDA approved in July of last year, and I've been prescribing it since September when it became commercially available. It works very similar to the way that topical ivermectin worked, except for this is actually made for the eyeball. It's an eye drop. So it also affects the calcium gated channels, and it causes paralysis and mites. It's in a multi-dose preserved formulation with sorbate, so we're not using a harsh preservative, which I like. And it's meant to be dosed 2 times a day for 6 weeks. I get this question all the time from my patients. They ask, well, how does an eye drop get into your lashes? Well, it's lipophilic, so it moves in and out of the glands and alongside the lash follicles where they live to help them to become unalived. All right, next slide. The data was pretty shocking, and I love it when I see, you know, data that makes me go, really, there's no way that can work, and then it actually does. These patients were actually randomized for XDEMVY versus a vehicle, again, to dosed twice daily. It hits all the check marks of the studies that I would like, the randomized, the multi-center, the double masked. Next slide. Let's see what actually came out of that. They actually saw distinctive improvements in collarettes. It was 1 to 2 collarettes per eyelid by week 2. And remember I told you how long do these little guys live? 2 to 3 weeks. So this makes sense. If you had an effective Demodex eye drop, you should start to see changes in that time, because a lot of those should be dead by that time. There was also a 90% reduction in collarettes by week 2 and a clinically meaningful overall grade scale of 0 to 1. And so that's great. You're starting to see that pathognomonic sign disappear as early as 2 weeks, but that continued for that full 6 week. And then I get really excited about the secondary endpoints, because this is a really good way to communicate to your patients. Not only are you getting them to be less symptomatic, but the erythema, the redness of that lid margin goes down significantly, because you don't have this extra inflammation kicking up from the overpopulation and the extra bacteria that's living in there. So you get erythema that's statistically significant, and the redness is down. And then I thought it was interesting too that the secondary endpoint was that half of the patients in the study had mites down to a grade 0 by week 6, like not a mite. I've never seen any lid scrub work to this level of effectivity. All right, next slide. And it's shockingly comfortable as far as an eye drop for the ocular surface goes. Over 90% of people reported that the drop was neutral to very comfortable. Have you guys had any patients want to discontinue this drop yet?
I've had a few, just
I've
2. Yeah.
I've had one only, and that's in probably 200 patients or more. So it's not common. I'm kind of like Melissa.
Yeah, but it's amazing how comfortable it is. We're just talking about all the other options and how well it works. And I always like to tell my patients their eyelashes look so beautiful. They look shiny and glossy. And I don't like to use the word greasy at all. But how do you describe the eyelashes to your patients after they come back?
Well, I tell them about the collarettes. I tell them that, wow, those lashes look like thick and healthy, and they're pointing to action. We're starting to see some new lash growth where there wasn't lash growth before, because those follicles are no longer irritated. So, and I show them before and after pictures. I think that, you know, pictures worth 1,000 words. So it's really great to show them the change.
That's fantastic.
I agree. I just kind of caveat it with the fact that, you know, your lashes are going to look great within about 2 weeks. You're going to get rid of the grittiness, the itchy. You're going to think that it's completely cured, but that doesn't mean you can stop the medication, because they have, you know, these mites have 2 life cycles, and so they'll come right back. So it's just important, because it works so well, like you described it, so quickly, that I think there are patients who think, well, I'll just save the rest of the bottle. I think it's done everything it should, and they'll all come back. We learned that the hard way with blue mask, LLLT, and IPL. We used to treat them at 1 week apart, and I was amazed at how good their eyelids looked. And then a month later, they'd all come back saying, it's back. I don't think that was worth it. I wish, instead of treating a week apart, I should have waited 3 weeks to get the next life cycle. But hey, this company figured that out, and now we got a better treatment. So this works well.
Great. Okay, next slide. Okay, so here's what I'm excited for next, because they're looking at potentially expanding the ability of this drop. It hasn't gone through, this would be considered off-label use at this point with the URSA phase 2A study, but they basically took patients who had concurrent meibomian gland dysfunction and blepharitis, and they kept these patients on the drop for a full 12 weeks and compared twice a day to 3 times a day dosing to see if they could see improvements in meibomian gland secretion score and overall secreting glands. And they did. So I'm really hoping that we see the expansion of the number of, this being repetitive and expanding more people into the study, because I don't know if you all have noticed meibomian gland improvements in your patients with concurrent MGD and blepharitis, but I've definitely seen some improvements when patients have taken the full 6-week dose.
I have too, and this has really changed my practice a little bit, because I used to kind of look, if they had, grade 2 Demodex, I would definitely put them on lotilaner, and even maybe grade, because I know they get worse. They're going to lose their lashes. They're going to get, dry eye. There's so many things that could happen if we don't treat them a lot. And I think it's the #1 cause of hordeola and chalazion or Demodex. But, if they only had like 3 or 4 lashes, I kind of hesitated. Now I'm not, because I look at the IRSA data and I think you've got MGD and you've got at least some signs of Demodex. Let's get you started, and maybe we'll help the MGD, which is probably related to your Demodex. And that's what this study kind of showed as well.
That's exciting. All right, next slide. And then you're going to go a little bit more, I think, Paul, into intense pulse light. Again,
Sure.
the FDA approved intense pulse light for Demodex blepharitis, but we do know that these mites, because they have a little bit of pigment in their cytoskeletons, will absorb the light from intense pulse light, and it will, kind of help to control their populations. We do have histological analysis and live video evidence of this. Next slide. And here's the data for it. The first time they ever described intense pulse light's ability to kill Demodex was all the way back to 2002, when we weren't even talking about mites for the eyelids. So there's the updated information if you're looking for a bibliography on IPL for evidence. Okay. And then just a couple of reminders. IPL is usually a series. This is a really fun picture that everybody loves to cringe at. It is off-label, usually a series, not a single treatment session. And just remember that if you do treat on the eyelids, every device is off-label for the eyelids, even the FDA-approved ones. So just remember that when you're considering this as a treatment. So there we go. And that segues really great into meibomian gland dysfunction. Take it away, Paul.
It was perfect segue. In fact, that IRSA study really tied in beautifully to this, because that went right into MGD in patients with Demodex. And, MGD is something, meibomian gland dysfunction, that is, I think, the #1 thing out there. And yes, it will lead to evaporative dry eye. And that's why the first, if you look at all the patients who have dry eye disease, hyperosmolarity, clinical dry eye, 86% of them have MGD. That doesn't mean that's the only cause. There's about 35% that have a mix, but still 50% are just MGD alone related dry eye. The ones that stand out for me are prostaglandins for glaucoma, 96% of people. And I talked to the author on this. He said, well, it's probably 100% of people on prostaglandins with glaucoma that develop MGD, but it came out to 96 when we did the statistics on it. And non-prostaglandin users for glaucoma is still pretty high. Diabetes at 58, contact lens wearers 60%. And, it's kind of interesting, because if you look at some of the other studies out there, Triton study, for example, if you took the contact lens wearers as well, it was near 60% had Demodex. So it's interesting to see all these overlaps, and not saying they're both connected by the same, but there is a lot of understanding the eyelids is so critical to managing ocular surface disease, and MGD is so prevalent. Next slide. So the key, I think, to managing, people say, well, that's the key to managing dry eye disease. I think it's to start with the eyelid. I think that's where 86%, as we talked about, of dry eye has some meibomian gland dysfunction, 96% of prostaglandin glaucoma users, 60% of contact lens wearers, 80, and we talked about 86% of the dry eye. So, and it doesn't mean MGD is necessarily dry eye. It goes to that if you let it go. And that's why it's so important to look early at the eyelid. Next slide. Sometimes you get obvious things. Saponification is a great indicator for meibomian gland dysfunction. It means that you've got an early case, which is a wonderful time to treat it. I love that the eyelids and the eye and dry eye ocular surface disease always seems to match so beautifully as a puzzle. Every day I'm in clinic, I'm like, this is the easiest field in the world, because things all line up. Like a patient who has, meibomian gland dysfunction early on gets the enzymes in the bacteria, and those carried by Demodex, which is just what Tracy covered, react with dysfunctional lipids, which is MGD. Isn't that amazing how this all ties together? And you get soap. And if you talk to these patients and say, what's your chief complaint? They'll say, my eyes burn and they sting, just like getting soap in the eye, and I get fluctuating vision. everything lines up so nicely when you start to look at these patients. But for the majority of patients, you're not going to see frothy tear film. In the next slide, you're going to see it's more likely that they're going to have chronic disease, and it's harder to treat chronic. I tell patients all the time, you've had 3 decades of building this up. I'm not going to reverse it in 3 weeks. It's going to take a little time. And if you look at this eyelid, there's so much pathology. There's telangiectatic vessels. There's collarettes at the base of the lashes. Of course, Tracy showed it on the upper eyelid, which is a much better place to look for eyelid collarettes, but it's there too. You see, look at the cap glands. See those white tops on the glands? See how far posterior they are? It's a sign of chronicity. That's long standing. You got thickened eyelid margins. You've got debris in the tear film. It's hard to see it in 2D, but you actually have scalloped eyelid margins there. They go up and down a little bit as you're there. So there's just so much going on when you look at the eyelid, and that's the level of detail. Now, that takes 10 seconds, 20 seconds, but it's not a long time. And that level of detail will really help you to know what to do. Next slide. But you got to have them look down too. We saw the same thing. Such a great indicator for collarettes, an easy way to make a diagnosis. And we just saw the URSA study, which talked about meibomian gland dysfunction related and the improvements you can get when you treat them with lotilaner for the MGD component alone, let alone the Demodex blepharitis. Next slide. Expression, so important to do this. I have docs who come in on, or more often even students say, Dr. Becky, I love this dry eye stuff you're teaching. Do I have to do that expression? Well, you kind of do. According to Don Corp's word, 72% of all patients who have MGD have what's called non-obvious. Unless you express it, you wouldn't even know. And it's kind of like saying, I want to treat macular degeneration, but do I have to look at the macula? You kind of do. If you want to treat dry eye, you've got to see what comes out of these oil glands. And 72% of the time, you won't have any signs like the last 2 slides, early 2 slides, unless you take 5 seconds. And it's not a hard thing to do. You don't need anesthetic. You could use your fingers. You could use a wet Q-tip. I like this paddle. I think it's just what I got trained on. It's easy. You just keep your thumb stationary and you milk upwards with this from the back. You just have to test the lower eyelid. That's the best place to see what's going on. And lower nasal to central is the best region for testing. So you're talking about a 5-second test once you get good at it, and you're not trying to force it. If it takes a lot of discomfort to get anything out, that's all you need to know. The glands aren't functioning. That's MGD. If it's toothpaste there, that's MGD. If it's turbid, if it's discolored, it should be olive oil, should be thin, and should just flow out naturally where you can't hardly even see it. Next slide. Here's a good example of, patient who has dysfunctional lipids. So this is classic MGD. If that came out like olive oil where you wouldn't see it at the top like that, that would be normal. This is not normal. This is a patient who's been complaining about dry eyes for a long period of time. We know it's evaporative MGD related. Next slide. Meibography is helpful. I've had patients who had perfect glands and I had no expression. I've had patients with very few glands like this with no expression. It does help to know the level of it. What's most fascinating to me is there's a study by Corb and Blackie that I know I quote Corb a lot, but he was like 15 years ahead of everybody in this field. So if you look at the research, it was all his from like decades ago. So you really almost have no choice. He was that far ahead in his knowledge. And you only need about 6 glands to function, to be asymptomatic. So you look at an eye like this and think, oh, there's no hope. Hardly any glands. Those little dark dots or those nubs are all you've got on this patient. Ironically, this is actually a Sjogren's syndrome patient. Sjogren's syndrome patients are amazing because early on, they have perfect oils. I have over 800 Sjogren patients in my clinic, and a lot of them come from rheumatologists where they're like, okay, this patient's complaining about dry eyes. There's this one guy who's into this stuff. I'll send you over there. And they diagnose them early, and they have great oils. But when their oils start to break down, their meibomian glands break down, they go down fast, and they can look like this in due time. But if I have 6 nubs, I could still make them at least functional. Next slide. Also check for inadequate lid closure. That's the #1 cause of non-responsive dry eye in my clinic by far. And these are patients who complain about morning symptoms. Dry eye shouldn't start in the morning. It should be the best time for them, should be in the morning, and it gets worse as the day goes on. If it's actually bad in the morning and a lot of symptoms, their eyes just simply don't close. And it's fascinating how often you mention that to a patient. Here's the Corb Blackie test where you darken your lane, you grab a pen light or a transilluminator, you have them close their eyes like they're sleeping, but don't squeeze, and just put a light up here without pushing. and you see this nice beam of light coming down below. It's almost like a party trick. It's like, wow, look at that. That comes through. I was amazed by seeing that. And these patients will say, you know, I've been told my eyes are open. I had no idea that was the cause of all these problems. But your meibomian glands recover overnight if your eyes aren't sealed. They don't. This is not like ophthalmos. You don't have an eyelid up here and an eyelid down there. That you can have that too. Don't get me wrong. And this test would show it. This is where eyelids are supposed to seal at the tip, and the opening is like that. But it doesn't matter if your eyes are open like this or like that. You get the same poor results, and you get a lot of Demodex, and you get a lot of MGD, and eventually get exposure keratitis. Next slide. I do find that my success for treating evaporative dry eye, which is MGD related, involves what I call OBIT. I've got to treat the obstructed glands. There's a lot of ways to do that, from IPL to other things. I got to treat the biofilm. I've seen eyes where I couldn't even tell there was much blepharitis, but I still had them do a lid scrub after the fact, and their eyes got a lot better. There's a lot, as Tracy showed so well, there's a lot of pathogens when you have meibomian gland dysfunction that are there. Sometimes you see them like collarettes in the case of Demodex. Sometimes you see staph and debris and other bacteria, but most of the time it's there without you even seeing it. I know that sounds so weird. I gotta treat the blepharitis when I can't even see it. It's in the glands. Sometimes it's just adding that step in does so much for the evaporative dry eye patient. Yes, you got to treat inflammation. We all know inflammation is part of dry eye, and eventually the tear film should get better on its own, but you may have to treat that at the beginning too. So sometimes there's multiple things, like IPL treats the obstructed glands, especially with LLLT. It treats some of the biofilm, and it treats a little of the inflammation. So there could be things that overlap. If you're using something like the new perfluorohexyloctane, which was studied only in meibomian gland dysfunction patients, it's mainly treating the tear film, but it also helps a little bit with that evaporative stress. So you may get some inflammation that goes down in time. That doesn't mean, though, I don't want to get rid of the obstruction just because they're on a drop that helps mimic the lipids. I love it. It works well. I'll start them on that, but I got to get them to a better stage. And if there's Demodex, you got to use the things that Tracy described. Next slide.
And the perfluorohexyloctane actually works even better with the natural oil of the eye, right?
So true. It's a semi-fluorinated alkane. Alkanes need lipids. You're right, Tracy. If you don't have good lipids, you know, the only people I get that say, I don't like this, it's kind of sticky, are those who have almost no lipid layer, because there's nothing to anchor the semi-fluorinated alkane. You're spot on. I'm a big fan of debridement. I think that's an important thing to do too. It's amazing what you can remove. You can open up the glands. I don't know if the video will run here, Melissa, but that ability to just run it across, you know, just over the orifices, you pick up a lot of debris. You know, and there's now heated debriders. That's pretty cool. I like that a lot, where you can actually run that across and use it as almost an in-office treatment tool. This is one of the first ones I did. And I thought, well, why put in, you know, I thought I'd put in one that takes me 5 seconds. And I thought, that's not fair. I've been doing this for 14 years. Maybe I should put one of my early ones. So one of my early ones, I'm not that good at it. You don't need to go to this level. You can just run it across quickly, but one direction does help. I'm always fascinated by how much stuff comes off. Don't use anesthetic. Patients love how good their eyelids feel when you do this little procedure. I've had patients practically tackle me if I forget not to do this at the end of exam. Now, if you're doing the heated debridement one, you should charge for that and do the expression with it and all the other things. But if it's just a debridement, just make the patient feel good and let them go. I don't add in any sort of billing for that at the end of the exam. Next slide. The next one after that. Sorry, it's hitting again. Hot compresses do work. You just have to have one that has enough moisture to make it the length of time you need. and that is about 8 to 10 minutes. So it has to be moisture. If you put your hand in a dry heat, like an oven, you won't burn it unless you touch the racks or you wait, you know, a minute. And that's 400 degrees usually, 350 degrees. But if you put your hand in boiling water, which is 212 degrees, it'll be scalded immediately. And that's why you have to have moist heat. Dry heat will not penetrate into the eyelids to help the meibomian glands. Next slide. So compresses, a good study. Is this yours, Melissa, or is this mine?
Yeah, so this is a great study that I love to share with my patients, and that is by doing a warm compress can increase your comfortable wearing time of contact lenses. So it's also a study I like to share with myself to remind myself to do warm compresses. So in this 4-week single center 3-arm randomized study, this was using the Bruder compress twice a day or once a day, or a warm washcloth used for 10 minutes twice a day without reheating. There were 51 patients, 98 female, in this study, and those in the Bruder moist compress group noticed a significant improvement in their comfortable contact lens wearing time, which is so important. So this is a study I tell my patients all the time. It's something that can really help. And I used to tell my patients, I'd love to know what you two think. I used to tell them when to do the compress. And now I just, say whenever it fits into your routine. Like if it's easier in the morning, that's great. If it's more comfortable in the evening because it's very relaxing, that's great too. If you can do it twice a day, fantastic. And so I let my patients sort of choose the time of day that they do their compress. What about you two?
I'm the same. I think you just want to get as much compliance as possible. I agree with you fully. If they're willing to do it, that's the key, whether it's morning, evening, when it feels best. Twice a day had only a slight incremental improvement in a study that was done by Nichols once. It wasn't statistical improvement, meaning that the one is the large majority effect a day. If you do a second, you do get a little extra benefit, but I would say even if they're willing to do once a day at any time, like you said, that's sufficient.
Yeah, I think initially, if someone is very symptomatic, twice a day for a few weeks is beneficial, and then go down to once a day. If they can do it once a day, that's great. If a patient can do a warm compress a few times a week, that's better than nothing as well.
Yeah.
Good to take a midday break if you're a computer user too. So sometimes it's good to take that, time to close your eyes and just let them get rested anyway midday. So midday is popular for computer users.
Oh, that's a great idea.
Good thinking. We talked about perfluorohexyloctane. It's amazing that it really truly mimics the lipid layer. It's actually better than a 50-year-old patient. They did a study where they compared a 50-year-old healthy meibum, not the stuff we showed earlier, but the nice olive oil consistency against perfluorohexyloctane, and found that the perfluorohexyloctane prevented evaporation 4 times better. So it's not like, 1-year-old meibum, those young babies. I remember my children, I couldn't get them to blink. They have such healthy meibum. It would drive me nuts being a dry eye guy, but they're fine. But age 50, this showed 4 times better at preventing evaporation. It is dosed 4 times a day, but quite frankly, most people it's 3. There are some that do 4. Water-free, preservative-free, steroid-free. I see the only disadvantage of this drop is it's too comfortable, and so patients don't feel it going in as a whole. And it's also a small drop. It's only 11 microliters, which is 1/4 the size of a normal drop. So you have to really educate them not to put in too many drops. One's probably there, and you'll notice it by, you'll feel it towards the edge, outside edge of the eye. Next slide.
They risk running out, right? Have you had patients run out if they forget that fact? Yeah.
That's really well said. And we talked about this, creates a little monolayer, lasts about 6 hours. So that's why 4 times a day dosing seems like a little much for a 6-hour drop. But some of the severe patients that aren't so severe that it doesn't anchor, we'll do 4 times a day. Most people are 3. And then, yeah, we talked about the 4 times more effective at inhibiting evaporation. Next slide. It's very tolerable. In fact, if you go to the next slide, and the data is good because it hits statistical improvement in symptoms and signs being total corneal fluorescein staining as quickly as 2 weeks. See the high statistics there, maintained for day 57. Next slide. Symptoms were also achieved within 2 weeks, by the way. This is the key, though. There was no serious adverse events. 1 person out of 614 dropped out of the study. 1. So always that 1. 3 people out of 614 mentioned burning, and 13 out of 614 mentioned a little blurred vision. So I've never seen a safety profile quite like this to date. But the drop size and the non-ocular sensation or blink reflex does make it hard for patients, as Melissa, I think, mentioned. They may use the drop too much. Next slide. Biofilm removement's important. That could be blepharoexfoliation. Next slide, where you can see some biofilm there. Studies have shown that our lashes do carry a lot of harbor in patients with evaporative dry eye, carry a lot of bacteria or Demodex. It's kind of pathognomonic there too. Go ahead and next slide for evaporative dry eye patients. So here's a patient on your left who has a lot of collarettes, and on the right, it's hard to see these videos, I think, and we'll go past them. Complete clearance, but keep in mind, if you're going to do blepharoexfoliation, which is that removal, I think it's important. Patients do well. You bulk the eyelid, but you still have to put them on a load lantern to kill it. This kind of gets rid of the sawdust, but not the termite. There's thermal expression technologies. You're going to hear about one at the end today that's pretty amazing to me too, that can heat the eyelid glands and really make a difference. In fact, a recent study on the upper left one showed that using those applications compared to cyclosporin, 0.5%, that's the older cyclosporin, actually had better results with these treatments. Next slide. IPL, I think we've covered this, but I think that's a good treatment, especially for patients that have no expression. Next slide. And also treats rosacea, it treats the blood vessels there, it activates the glands. The only thing I tell patients we get from 0 to 60, meaning no expression to actually working, is with this. If I get expression, but it's not quality, I could use any of the other things I just described, the thermal pulsation, things like that. Next slide. It's a study on LLLT, shows it is different. If you just do IPL and try to express glands, you're not going to get much expression. There's not enough heat. The heat didn't even last 2 minutes after an IPL. But if you look at the one above, next slide, you'll see that LLLT, low light level therapy, actually statistically heats the eyelids for 25 minutes after the treatment. Still statistically hotter. It means there's endogenous heat there. And that's why you can use it to get rid of hordeola and sty, is what patients call it, of course, and your chalazion as well, with pretty remarkable results. Next slide. And then we covered Demodex blepharitis, I think, pretty thoroughly, but now I think we pass it over to you, Melissa. Is that right?
Well, there
Actually,
just a few highlights here on Demodex, and yes, we did cover it, but it is really important. We talked about everything that it's associated with, these collarettes, contact lens wear, cataracts, blepharitis, glaucoma, MGD. Lotilaner, we talked about that as well. But I do want to just touch on the patient experience and the communication that we have, and that to make everyone very aware. We have a product, it works very well, it's effective, it's fantastic. But we have to be a little cautious when we're talking to our patients and be sensitive in the communication that we're having around collarettes and mites. Now, there's some great materials that we can give patients now that we can educate them. But we've all had patients who have gotten pretty scared about this, have looked online, looked up Demodex, have done things like shave their heads and their eyebrows and come into my clinic and like, did you know that this thing exists? And so just have a little empathy with your patients, talk to them, sort of get the feel of your patient when you're talking about Demodex blepharitis. But it's wonderful that we have some great new treatments now.
Omega fatty acids, I will tell you, I definitely lean towards what the research shows. There's been a lot of debate with the DREAM study on just fish oil as not being that effective. It actually showed improvement. It just didn't show better improvement than, let's say, the placebo. But there's plenty of amazing data when it comes to GLA-based supplements. So that's a 6 that in the presence of EPA, which is a component of fish oil, does convert to PGE1, which is probably the most direct anti-inflammatory medication out there. There's studies on perimenopausal women showing statistical improvement, Sjogren's syndrome patients, MGD patients, aqueous deficient patients, PRK patients, contact lens wearing patients, and even mild to moderate dry eye, all statistically improved. So I will tell you, it's good to lean towards that if you're going to lean in there. There's also, nasal sprays that can activate the meibomian glands too. Just make sure you're spraying down in this corner here. Next slide. So the inside, and you see the data there and showed that significant improvement. But if you go to the next slide of signs and symptoms, and there are your symptoms, you're going to see that a lot of these patients also showed improvement in their meibomian gland, improvement in our lipid quality. Next slide. And you can kind of fly. And then we talked about ILS, inadequate lid seal. You can use ointments. They have about a 60% success rate. Sleep masks have about a 30% success rate. And the reason is they can't anatomically pull the eyelids together, but that's still some benefit. You'd have to tighten them too much, and that could risk glaucoma. But these are very impressive for patients because they're hypoallergenic, oxygen permeable. They actually allow the porous, because they're porous, that movement of air through that. And so patients can get the actual anatomical improvement. I tell patients, you've probably heard of, these nasal strips, and everybody's heard of them. I said, there's actually eye strips that can close that eye that's open, like you have when you have symptoms in the morning. And when patients can use this, the success rate's pretty amazing. The MGD goes away. The blepharitis clears faster. The dry eye disappears, the exposure keratitis, and many don't even have dry eye. They just had dried out tissue because their eyes were open at nighttime. So this has been a great new addition as well. Next slide.
Excellent. So we're going to touch on a few other things here too, because when we look at eyelid position, we can see here, and this is a mother-daughter combination, you can see the difference between the two. And here we're talking about ptosis. So ptosis is an abnormal low-lying upper eyelid margin. We can have congenital ptosis, we can have acquired ptosis. Ptosis can be unilateral or bilateral. And I'm going to just get right to the acquired ptosis because it's something that we see very commonly in our patients and very commonly in our clinics. So when I'm looking at my patients, I'm looking at them now from across the room. I'm looking at them and looking at their eyelid position and looking for some mild asymmetry. And then you can evaluate so many things by looking at your patients from outside the slit lamp before they get behind the slit lamp. And I have my patients close their eyes looking for things like Demodex, also incomplete eyelid seal, lag of thalamus, etc. But with time, I don't like to say aging or old at all with my patients, but with time, there are some changes. So you can think of this like presbyopia. There are some natural changes that occur to the upper lids. There are changes that occur to the levator muscle that can cause ptosis. Now, we want to be careful and differentiate between ptosis and dermatochalasis. And oftentimes I'm holding up my patient's eyelids and saying, it's going to help this and not this. And then talking to them, whether we talk about a pharmaceutical option or a surgical option, whatever it might be. But ptosis is something that fortunately we have a treatment now that is non-surgical. What I learned is so interesting. We all know with corneal gas permeable lenses pulling on the eye, I always thought, yes, that would cause ptosis, but it's any type of contact lens wear. So even soft contact lens wear too. Cataract surgery is a huge one without lid speculum, holding open the eyelid, or retinal surgery, or any surgery at all. Injections can do it too, but this is a highly prevalent condition. 13 million people over the age of 50. This was in 2020. And 1 in 10 adults over the age of 50 have ptosis. All of you know that we do need to differentiate from neurological disease if it's a sudden droopy eyelid, if there are any other conditions associated with it, double vision, pupil changes, etc. That is an emergency, and that is not something that we're going to treat in a non-surgical way. We have to work that up. For ptosis testing, we can check things like MRD1, the distance between the center of the pupillary light reflex and the upper eyelid margin. We can look at the levator muscle function, and the normal range is 15 millimeters. We can evaluate that eyelid crease height and check visual fields as well. I do recommend having your patient self-assess for their eyelid position, because it's really amazing when you ask your patients, what do you think about your eyelid position? And something that we might think is a very mild ptosis might really affect a patient. And ptosis can affect the wellness and vision for our patients. It can affect the appearance, psychological effects, the quality of vision. If we're thinking all those patients who have premium IOLs, and we of course need to address the ocular surface, but sometimes they're not as happy as we thought that they might be, you might want to consider a repair for ptosis, either a non-surgical or surgical repair as well. Of course, we can have brow aches and headaches and all that. So fortunately, we do have an option which is oxymetazoline. So this is a potent, direct acting alpha adrenergic receptor agonist. I always tell my patients it's magic, but it actually is not magic. It has a 5-fold greater affinity for those alpha-2 receptors, and it targets the receptors in Mueller's muscle, causing contraction and lifting up the eyelid. Now, a common question is, well, can I use that for my patients who've had eyelid surgery? Well, you could give it a try. Can I use it for my patients who've had trauma to the eyelid? Yes, you can do that as well. So it actually works very quickly. It works well. You can see a few different patient examples. I love my patients who are 80 or 90 years old and they don't want to have surgery, but it's helpful in the 20-year-olds who have ptosis too. So just think of that as an option. Now, I know we do have a few questions that we're going to cover, but I just want to highlight the TFOS Lifestyle Report on digital eye strain. And the new novel definition is the development or exacerbation of recurrent ocular symptoms and/or signs related specifically to digital device screen viewing. Digital eye strain is highly prevalent in all of our populations, up to 97% of patients. And we know that digital device use and dry eye go hand in hand. So these are some really helpful tools. You can look them up, you can download them on digital eye strain mechanisms and symptoms, and it gives actual information of treatments for our patients and recommendations. And this is again from TFOS. So on that, we're going to answer a few questions. And again, it's been such a pleasure to lecture with my distinct colleagues.
That was amazing. What a great overview. Thank you so much to all of you.